Hey everyone, welcome back to the podcast. Today I have Dr. Stephen Barrett. Super excited to introduce him because he's not only trained 6,000 other physicians, but he's a very deep specialist in pain and pain management and has done a ton of work and has patents in the industry. So he has a medical degree and medical expertise, unlike most people, even in the medicine space. He has this very unique view because he's looked under the hood of so many people. And he just comes from a different perspective that I'm super excited to share. Some people are longevity, some people talk about supplements. He's done all of these things and has years and years and decades of experience over me and most people. So let's dive in. It's going to be super awesome, and I know you'll enjoy it. See ya. Dr. Barrett, welcome to the show.
Thank
Very
you.
excited to have you.
Likewise. Thanks for inviting me on.
It's ironic because usually I meet people I have on. This is our first time meeting.
Right.
And I'd like to start with a question I'm very curious about. You've trained 6,000 surgeons, I believe.
Yes,
That's a lot of surgeons all around the world.
that's correct.
Can you share some of the best ways that you've learned to teach people? Because I think, A, that's a very specific skill someone needs to learn and be good at it.
Right.
B, doing something 6,000 times. I'm dying to know what the secret is to making them amazing.
Well, I guess the secret is being old and in the game for a long period of time. And so when we first started out, we developed in 1991, developed the first endoscopic surgical procedure of the foot called endoscopic plantar fasciotomy. And at that time, we didn't have any aspirations of developing any training modules or anything. And then people started, once we published some of our initial data, people started coming in and requesting, hey, can you train us? So we started, and I remember our first course, we had maybe 6 surgeons, and then the next one, 17 surgeons, and then the word just kept spreading. And then we would train as many as 120 surgeons in a weekend. Now, I had supporting faculty, of course. I can't personally treat or train every single person, but then we started getting invited to the state society meetings, the national meetings, and that would bring in 400 or 500 candidates for the training course. And I think the largest one we ever did was about 550 surgeons over in Spain, which was just insane, but we had enough faculty to do that. And so it just kind of happened. It was not anything by design.
That's awesome. Have you found when training that many people, is there some key takeaways you can share with us in terms of how you approach training somebody that we could take into other ways? Like, I'm growing a business, I have to train people on new procedures. It's always kind of some friction or ways to improve. Maybe you have some insight on that. And it'll also be applicable to people, physicians and or not, trying to train new habits.
Right. Well, I think the most important thing is what we did is we had a combination of a didactic program as well as a cadaveric workshop. So we would spend 4 to 6 hours actually in didactic training where we're talking about the anatomy, the appropriate indications, what patients to select, what patients not to do the procedure on, and then all of the nuances of the procedure. And then we tried to take that and then go into the cadaver lab where we would do actual hands-on, which is really a very important part of any surgical technique, is actually having them do it on a cadaveric specimen. So that was the combination and the way we trained it. And then we would show a lot of live surgery tapes that we recorded so that they could see, and then they could take those videos home after they would do the procedure. Now, some surgeons who I respect greatly would call either myself or they would call one of our guest faculty members in to actually go and monitor them when they're actually doing the surgeries for the first couple of times. And I remember flying into places and people would have, 16, 17 surgeries scheduled in one day that I would basically go in with them. And that was the optimal way. I mean, because there's a learning curve to everything. And that was the fastest way we could get over the learning curve.
Yeah. So doing it and adjusting as needed.
Exactly. And the ability to actually just take your hand and put it on the surgeon's hand and make it change the angle of the instrumentation, just something so subtle as that, which a lot of times that's very hard to teach in a didactic format where you're showing a picture on a slide or something like that. But to have the ability to take that surgeon's hand and move it and Oh, okay. So, because it's a psychomotor skill.
Yeah,
Yeah.
that's very interesting. Do you feel like I feel like surgeons might be a specific type of person. You've trained a lot of them. Has that held am I wrong or is that true or are they a specific type of personality? I think it's a very highly skilled position and a very important one, right? So I'm a little bit curious more personally, but it could be an exciting combo if
Yeah, so I think surgeons are you can make stereotypes about the groups, and there are some that are extraordinarily great people, and there are others that are extraordinarily not great people, and then there are some that have tremendous dexterity, and others that barely can make the standard of care as far as being safe and doing the procedure properly. But generally speaking, they're very good people. They have in their hearts a desire to have a great outcome because surgeons feed on outcomes. They'll remember the 2 patients that maybe didn't do really well versus the 100 before them that did perfect, right? So they're generally speaking, they're a special breed and they have the tenacity and the wherewithal to go through to try to get the best training they can in order to get the best outcomes.
yeah. No, that makes a lot of sense. And I think every industry will have varying degrees of skill sets, and therefore that's why people get higher ranked, higher pay, more referral, less referrals. So that
Exactly.
makes sense.
Yeah.
As you were doing that, how did you scale up? I'd be interested to know being able to go from training a couple of people to 500 in a weekend, what were some of the challenges there and what did you learn from that experience?
Well, we had some very interesting yeah, I'll tell you a funny story. So,
Yes, perfect.
in one of the early sessions that we did some training, this was maybe our third or fourth course that we taught, and it was down in Miami. And so we would have it's a big deal because you'd have to ship in cadavers, you'd have to ship in all your surgical instrumentation, and there's a lot of logistics to it. Somehow we just had enough great support staff that we were able to do it. But I recall this one time because it was so great of a story. We're teaching a course in Miami, and we like to get in there on a Friday night, check, make sure all the instrumentation is in there, everything, we get it set up, make sure that the cadaveric specimens are thawed out properly, all of these little things you wouldn't think about too much. And we got in there and we couldn't find some of the surgical instrumentation. They were basically the cannulas that we put in uh, with what's called a trocar. So the trocar fits into the cannula, and then we're able to introduce that into the foot, remove the trocar, and that leaves a slotted cannula so we can see the structure that we're going to cut. In that case, it's the plantar fascia. So for some reason, all the slotted cannulas were gone. Somebody had stolen them. They left everything else, right?
Yeah.
And so we went down to the front desk and talked to security, and we're in a big problem now because we've got a bunch of surgeons coming in, and we don't have the instrumentation to train them. And so anyhow, the security did a great job. About 3 hours later, and this is probably about 1 o'clock at night, we get a call. We found your instruments. So evidently, there were some workers that decided that they could use these to smoke crack. And so there we spent time, like cleaning out the charred material inside these cannulas before we were able to teach the course that morning. But I thought that was kind of a really interesting, funny story. So I'd never designed, I designed surgical instrumentation, but I certainly never thought I would design a crack pipe or something.
I guess if it fits, right?
Right.
Oh, cool. So I want to dive into maybe the next topic, which is pain. You obviously deal with that. Surgeons deal with people in tremendous amounts of pain. It's an interesting topic only because I feel like nobody cares about pain except it's the only thing they care about when they're in it,
Right.
right? And so maybe what are some of the ways that you've seen people deal with the pain and then how you've been able to help? And have you guys been able to educate those patients to not get into pain in the future, right? Because a lot of I'm not saying every time, but sometimes it's self-inflicted, terrible diet, not working out properly, whatever the case is. getting diabetes, like all of those things can influence where you need to do surgeries. And that's super painful. You get to a point where the pain is so strong, this has to happen. Maybe if you can touch upon that, because I know that's like a huge, how do you stop it? How do you mitigate it? And then how do you prevent it from happening?
Well, so I think let's start out with the fact that pain is probably the single greatest motivator for a person to get treatment or to seek treatment. And I didn't realize until I got into this arena how many people are in very severe pain, and it can come from a metabolic aberration. Diabetic peripheral neuropathy is an example of that. It can come from post trauma. So people have been in very bad accidents. They had very bad fractures, plates, screws, everything. Their orthopedic injury was completely taken care of, but they had nerve damage when the situation occurred, not necessarily because of the surgery, but consistent with the trauma that created that. The nerves are going to get sometimes very badly damaged. So they would come in, and I think the best thing that we could do is to identify the true pain generator. And one of the ways we're able to identify peripheral nerve pain generators is with lidocaine peripheral nerve blocks. So we can take a very small amount of, like, let's say 0.3 of a cc of lidocaine, and with our ultrasound imaging, we can find the nerve that we think is the contributing problem, put a small amount of lidocaine on that nerve, and then all of a sudden, 10 minutes later, how's your pain? And they'll say, it's 0 improved, or it's 50% improved, or some, maybe 100% improved. Well, if that's the case, then we know at least what wire is hot that we can deal with, and then we can address that in different ways. Many times, the nerve has just been scarred down and entrapped. And if that's the case, then we do what's called a neurolysis, which basically just means freeing the nerve from the scar tissue. That's a very benign procedure because the nervous system loves it when it's pinched and you unpinch it. I know that's not very good, sophisticated medical terminology, but people understand things being pinched, and and it doesn't take a lot of compression on a nerve to create a significant amount of pain. About 15% of our patients are suicidal at some point in time, and you would never have imagined that when you first get into this. I did a TED Talk a couple of years ago on a patient that we had done a diabetic peripheral nerve decompression on him, and he was in his mid 40s, and he came back very successful. He was a petroleum engineer, probably still is, but petroleum engineer, wife, kids, everything. And he came in and he said, I have this horrible pain in both of my legs. And I examined him. I said, I think we can do well with a nerve decompression. And he came back. We did his decompression. He came back 1 week later for his first postoperative visit. And the first thing he said is, thank you for saving my life. And I thought, well, I don't think I really saved your life. I made your nerve better and your life better. He goes, no, you don't understand. He said, I had everything planned out. If this surgery wasn't successful, I had the gun in the briefcase, I had the note to my wife and family, and I wouldn't be here for this visit had this surgery not worked. That was a very epical moment in my career, because then it made me realize how much these patients really are suffering and what great things we can do for them to get them out of this pain. So that's kind of a story, I think, that illustrates it all. But if you take a patient and they're in pain for a long enough period of time, the likelihood of them not having depression or anxiety, and usually both depression and anxiety because they're inextricably entwined, is very small.
I really like resonate with that. I think even like to bring it back to an everyday person, when you get food poisoning and you're throwing up for like 10 hours, after 10 hours, you're like, I'll give all my wealth away. I don't care about my house. Take all my clothes. Just make me feel a little bit better.
Right.
And at some point, you're like, is this even worth it? Right? Not like, it's not like that severe, but those thoughts come into your head, and you're just like, anything to relieve this, and I'll do it. the irony is as soon as you feel better, you're like, oh, I wouldn't actually give all my money, but it's like you would have,
Yeah, exactly.
back in that situation. I'm joking a little bit, but I think that's it's a very underrepresented point is these, like when somebody's in actual pain, like they'll do anything.
Yes.
Maybe do you feel like the companies have kind of taken advantage of that or made products that are good, but like I think maybe oxytocin was the like blow up case of,
Right.
hey, this really works, but then you absolutely cannot get off of it, not because you don't want to, but it's now just something that you absolutely need, so what, how has your approach been? If the pain doesn't go away all the way, is there other things that you incorporate into the care plans that are like, hey, look, even if we can't get there all the way, then what's it called? Is that okay? Cut.
It
Yeah, I know. I didn't want I saw your concentration shift, so I was like,
it it needs a little Viagra.
yeah, that's right. Yeah.
Cut that out.
No,
Yeah, that one's gonna be the viral post that.
that'll be a teaser.
Yeah. It should be, how do you stop pain? And then cut to him. It needs a little Viagra.
Let me know if it
Okay. Yeah, it's done well when you've done it super straight.
So what was the question again?
Yeah, we'll go back to it. So going back to what you were saying in terms of like pain management and reduction of pain when it's severe, it's like anybody will do anything in those situations. Maybe some companies have taken advantage of that or taken it too far, i.e. the Oxycontin case was a big one recently, right? Where it's like, yeah, it helps, but then you're hooked on that thing for life. And, did they know or not know? We'll leave that up to the courts. But, in your practice, in your situation, having dealt with people in lots of pain, have you guys implemented, or can you share some strategies that you do post maybe surgery to kind of get them back on track? Things that are helpful. Maybe the pain doesn't go 100% of the way just because whatever reasoning or whatever the body mess up was, outside of your control. Can you share a little bit about that?
Yeah, of course. I think that's a great comment. I think the first thing is the opioid crisis. The pendulum always swings way too far one way or the other way.
Right.
And I had patients that I'll give you an example. We had a retired state trooper, and he was sent to me from a VA hospital in Phoenix. And for them to send somebody outside of the VA to a non-VA provider, that says a lot. But anyhow, he had a very severe nerve injury, had some failed nerve surgeries. We took him back, and we did some very sophisticated procedures with nerve transfers and grafting. And he came back in first post-op visit, and my question was, well, how are you doing? And he said, I almost died. And I said, what do you mean? He goes, well, the surgery eliminated all of my pain, so I stopped all my OxyContin immediately. He said, because you don't realize, I used to arrest people for having this pain medication, and I didn't feel good emotionally about having to be on it. So one of the things that's interesting about the opioids is that there are a lot of people that's the only way they can manage and have a functional life. And if it's titrated by the right method and the right pain management, it's not a bad thing, because those folks can function perfectly well and have normal, meaningful, important lives. So he just went cold turkey and almost died from, going through the delirium tremens and all of these other things. So that was, I think, illustrative of a lot of these patients. They don't want to be on pain medications. And if you can eliminate that pain generator, you may not get them completely pain-free, as you pointed out, but if you can take somebody down like from an 8 out of 10 to a 3 out of 10, now they can start functioning. The human body is absolutely miraculous. Once you get the body dialed down enough, it can then start to take over, and then you can do other things to augment it. Now, one of the things that we really look at is what's their their metabolics. Are they inflamed? These are things that we want to take care of and try to get them better. Perfect example of this is diabetic peripheral neuropathy. And in diabetic peripheral neuropathy, most, if not all, of the symptoms are due not to the metabolic effect from the diabetes, but actually because the metabolic effect causes nerves to swell. When a nerve swells, it gets caught in tight tunnels like the carpal tunnel in the hand. So now you have a focal nerve compression on top of the metabolic disease. So we did very well when we first started doing these surgeries around 2000, 2001. We had a 90% success rate of the reduction or elimination of pain, which was huge for patients. We had improved sensation at about 75% to the point where it was protective, which means that they would not develop an ulcer. If they got a pebble in their shoe, they knew it right away. They were take it out versus the poor person who had no sensation, walked around on a BB inside his work boot all day long, and then came home with a bleeding ulcer that's the size of a golf ball. So that surgery worked very well, but still we had folks that did well and met those criteria, but they then would still complain of, I still have small fiber burning and these things. And then that forced us to go into the functional medicine space a little bit, where we had to look at, well, what is their fasting insulin level? How insulin resistant are they? What's their levels of inflammation? All of these things. So then we had to treat them in addition to that. So it's not simply, I'm a surgeon, that's my hammer, and everything is a nail. I wished it was that clean and tidy, but it's not.
Yeah. No, I think it's a really good point, right? Because it notoriously come down to, if you've been making decisions, for example, like a diabetic example, right?
Right.
I think most people would agree you don't become born diabetic. It's something that progressively happens, and that's X amount of decisions a day over X amount of years, and all of a sudden the pancreas is like, all right, well, we're kind of done with you in as many words. And so then it's like, how could one day or one surgery all of a sudden fix it when it was something that, was done? Whether you knowingly or not did that to yourself is I'm just giving that context. It was something done to yourself, right? And I think that kind of gets lost, and sometimes it's like surgeon just nails or hammer nail, and as you said, that's not true. Like, there's a lot of context that has to be put behind it, and then it comes. Yeah, I'm gonna like maybe paraphrase the patient has to have some ownership of that and do a care plan that is adjacent to.
But the important thing is most of these folks don't know why they've gone through this process, because the population in the United States is at a huge disadvantage. The food industry has put all kinds of crap into the foods. People think they're eating healthy because they're having a glass of orange juice. Well, they'd be better off just having the orange rather than juicing it and then now having that super hyperglycemic effect. But they don't know. They haven't been educated. Our health system's entirely broke from the standpoint that we're just disease treaters. We're not disease preventers. And we could switch that paradigm, but it won't be switched because there's no financial incentive from big pharma to get people off of medications, or big ag to clean up the toxicities that are going on with, all the amounts of things that they're putting on things that we think are very helpful, like oatmeal. A lot of people think oatmeal's really a healthy thing, but then when you learn that a lot of the ways they dry the oats when they're still wet is they spray it with glyphosate. It's like, well, why don't you just poison these people? So I think there's a tremendous amount of power in patient education. That takes time, but that's what we do. And once a person understands the physiology of what is making them sick, they become much more compliant in trying to make themselves better, because most people really want to feel better and be better. But if they don't know how, then they're kind of like stuck, So I guess we just need to spend more time really looking at what is causing this problem versus just giving a pill for a symptom.
Yeah, very well said. And I think I'd love your take on this. so we can educate all we want, right? Just to play a little bit of devil's advocate. But then what situation are you putting those people in? For example, if I'm traveling, which I do quite a bit of now,
Right.
at the airport, I can't get organic food. I can't, I don't control that situation. So then because I know these things and we're in this industry, I could fast. I mean, okay, let's not eat at all. I could bring my own food and just eat that. I can do those things, but like, and then if I'm choosing things, I'll choose certain types. But somebody who's living in an environment where everybody's eating fast food, where they were taught that this is actually good for them, even though they know that's not true. How do you guys go about getting them to a place where they can make the decision, even when everything around them is influencing them in the way that, as you said, big food, everyone's advertising to them. It tastes good. It's instant. It's cheap. It's all the things a human wants, right? It tastes amazing. It's cheap. You can get it right away. It's cool. Everyone's doing it, right? So, what are some of the maybe strategies or even tactics that you guys are deploying that have been working really well in terms of keeping compliance up?
Well, I like CGM because then the patient realizes that popcorn that was perceived as being very healthy just shot their glucose up to 180 or whatever, right? And so patients do very well when you give them metrics. And there's a lot of things that you can't tell your blood sugar went from 120 to 180. There's just no physiological effect that says, oh, you don't get dizzy or anything like that. But that's then putting a tremendous amount of strain on your pancreas. It's pumping out more insulin. They become hyperinsulinemic. So I think one of the most powerful things is continuous glucose monitoring. And you can put somebody on a CGM for about 6 months. And they're pretty good for years after that because they know it's kind of like the Skinner box, right? The rat hears the noise or whatever, it responds. So if you have the CGM going on and they know I can't eat this corn chip because my body's sensitive to corn, well, after they stop CGM in 6 months or a year or whatever it is, they still remember, no, I probably shouldn't eat that. Now, your answer to the airport, I have that dilemma all the time because you don't want to just fast all of the time. But I think time restricted feeding is very powerful. And I think fasting is very powerful, but it's not easy and you need to do it properly and right. And there's a lot of books that will tell you how to do it, make sure your minerals are all, nice and electrolytes and all these things. But um, you can always go for the lesser of evils. So if you can't find anything that is ideal, let's say like I was in the airport yesterday and I'm trying to find some nuts and I'm looking at the package and every one of them has seed oil in it. And it's like,
I know.
why can't you just give me a damn nut that has nothing to it? But if I'm absolutely starved, maybe I'm better off with that bag of cashews with a little bit of peanut oil. I won't buy anything with canola oil.
Yeah.
I mean, I'd rather just go lick a muffler or something like that. That's how bad that shit is. It's terrible. But, and it's amazing that they can even sell that in the United States. So, but I guess it's just a matter of picking the less poisonous alternative.
Yeah. Yeah. In a pinch, you just got to
Yeah, sometimes you just got to do it.
No, that makes sense. Okay. Good. I think to your point, a lot of the time we've seen when someone puts the CGM on, even after they're done a protocol, we're seeing a lot of people wanting to stay for the accountability.
Mm-hmm.
And then others are doing other types of tests. So to your point, the empowerment piece, I think giving people the power, but also a feedback loop that's instantaneous has been a game changer for a lot of people because before it was like, hey, try this elimination diet, this one thing out of your diet for 90 days and then reintroduce it and then do another thing. I'm like, we're going to be like 2,000 years old, which we haven't lived forever yet. Like we haven't solved that. To eliminate everything and do that testing was kind of ridiculous when I was doing it, right? Is there any other technology that you're either privy to or looking at or using today or excited about in terms of health and health progression?
Well, I think, we're looking at everything from the gut microbiome
Yeah.
and, a lot of the blood biomarkers. We're doing cytokine panels to see how much inflammation is in that particular individual. Those are very powerful. The testing is becoming better and better. Even the gut microbiome tests are becoming more affordable for people with a little bit better, I think, interpretation. Some of the early ones were, I mean, it would come back. It's like, you can't eat anything. It's like, well, that's not possible, right?
I have to eat
You know,
something.
and so I think that's part of it. I think another really huge component is exercise and just educating people that it's not like they have to go to the gym and lift thousands of pounds of weight, just simple resistance training on a routine basis, just getting out walking, get 5 to 7,000 steps a day. And, these are things that they're integral, but they over time they build up tremendously. And then you'll you'll get the feeling that, yeah, I'm doing something really good. And you may not want to eat that piece of chocolate cake because you feel so good about the feedback that you're getting from the other things. So I think it's a comprehensive thing. When we look at sleep, people who have neuropathy usually don't sleep too well. Well, if you don't sleep too well, then you can't recharge your neurotransmitters properly, and so you can't downregulate the pain like you normally would be able to. So all of these things play together.
Yeah, no, that makes a ton of sense. Is there anything that's not in the market that you're either excited about or you would want?
Oh, well, I would love to have the market just get rid of all canola oil and seed oils.
Yeah.
I mean, if they just outlawed that in the United States, it would probably be there'd be some latency, but you would see probably a dramatic drop in a lot of the chronic diseases just from that, just because of the amount of inflammation that that's causing. The the other thing that I think is very worrisome for people is neurocognitive issues. And, they're referring to that as like type 3 diabetes. And, so I think there already is good testing where somebody, if they've had a family member that has had Alzheimer's or some other neurodegenerative disease, neurocognitive disease, it'd be great for them to get genetically tested so that they know what their ApoE alleles are. Are you a 4-4, a 3-4, 3-3, or whatever? Because then, and it's not a death sentence. If you're at ApoE 4-4, you're in a bad situation because genetics kind of dealt you a little bit less than ideal hand, but you still have the control, the epigenetic control. So you're able to, I think, have a higher sense of vigilance going, okay, I know I've got this. So no, I'm not eating that sugary cake. I'm cutting this down. I'm going keto or I'm going carnivore or whatever. So I think that testing, it's here. And if you've had any member in your family that's had that, that would be one of the first things that I would go to. You can do very sophisticated like neuroquant MRIs where they can look at, what's the hippocampus status and what's the thickness of the white matter, gray matter, all of these things that'll give you a baseline. So yeah, there are a lot of things that you can do. I think some of the interesting things that are happening now with transcranial magnetic stimulation, red light therapy that's able to actually go through the cranium and increase the neuroplasticity of the brain and upregulate the mitochondria. I think those are all magical things. But I think precision medicine is the future. It's expensive, but you're not the same as me. So why would we think that we're just going to arbitrarily throw out these routine treatment protocols and we don't fit in algorithms? I mean, humans kind of fit in algorithms a little bit, but not really. I mean, everyone is individual. You may tolerate a certain drug extremely well, where I may not tolerate it at all. Well, why not know that up front? Why just go to a physician and say, okay, I'm type 2 diabetic. What do I need to do? Well, just do this, this, and this, take metformin or whatever they do and get out of here because I only have 3 minutes to see you today. I got to see 70 other people today.
Yeah.
So if you take a precision medicine approach, you know what you're dealing with. So I kind of make the joke, if I called you up and said, hey, let's go hunting, what would you say? Well, yeah, let's go hunting, but what are we going to go hunting for? Are we going to go mouse hunting or are we going to go elephant hunting? Because we're going to take radically different guns depending on what we're going to hunt that day, right? So I think that's what I'd like to see is more precision medicine in the future.
That makes a lot of sense. I had a peculiar question here. You're talking about you guys deal with a lot of diabetics, as you mentioned. Obviously, diabetics always is tied to blood sugar or sugars in general, I think in the populace. Do you believe that seed oils have as much of an impact or contribute to getting diabetes and or making it worse? So would your statement be different for diabetics in terms of get rid of seed oils in the country, or do you feel like it would still be your number one recommendation?
Well, I think seed oils exacerbate every chronic disease we have. I don't know how much of a role it's going to play directly from development of type 2 diabetes, but it has to be an accelerant or another adjuvant that's going to contribute to, and if you ask somebody, and you can even ask a lot of physicians, what is the maximum or minimum amount of daily carbohydrates that you need to function as a proper human from a physiological standpoint? And they'll say, 60 grams a day or whatever they'll say. But the answer is zero. Humans can work really well. In fact, they work better on zero carbohydrates. You can do it all with the other macros. So, anything that puts a stress on the system, like an inflammatory stress, is going to be super negative for neurocognition. It's going to be negative for pancreatic function. So yeah, there's an interplay, and that's what I think is so frustrating about medicine is people, they look at one particular biochemical pathway. Well, that's nice in a biochemistry lab, but guess what? That pathway interacts with hundreds of other pathways. So I'm going to develop a drug to specifically hit this one enzyme in this pathway and expect the whole disease process to get better. That's why there's not been a successful Alzheimer's drug, because there's trillions of things going on. And the most powerful thing you can do is just get rid of the sugar, get their insulin down, and it's amazing what that'll do.
Awesome. Last thing on the diabetics. You see a lot of them. It's a absolute pandemic, if you will, and and not even in the States, like everywhere. Right. The highest growth rates of diabetics, pre-diabetics, and type 1, type 2, and pre is actually now Asia's Southeast, like those countries are on this J curve better than any tech startup that's had a boom. But in the States alone, type 1, type 2 encompasses about 90 million Americans, and then pre-diabetics, 90 million. A lot of them are not diagnosed properly, but that's the stats. So you're looking at pretty much like 70% of this country's population is in dire needs of help. Have you seen similarities in what gets them to those points? Is it just, look, they're so uneducated on food, so they just constantly make the wrong decisions, and the things that are marketed to them are addictive, sugary foods, which taste good, and they look fun because it's Fruit Loops or whatever the case is? Is it, is it like they're just very sedentary on top of, or maybe like they don't do anything? Is it sodas, which are super high in sugar, that they kind of sneak in? Is there just like common threads, or is it that like they think really big meals like in Texas are actually like just normal portion sizes? Like, is there things that you guys have seen consistently in diabetics that would be maybe a good discussion point or something people can take away from this conversation?
Well, I think that's a great question, and you could spend 8 hours talking about that because it's such an important question.
Yeah.
But I think the number one cause of the chronic disease in our country is the standard American diet, which is SAD. It's very sad, and you even have organizations like the American Diabetic Association still advocating that sugar's fine, which is absolutely astounding that you would have this organization to try to prevent the disease or to help ameliorate the disease. And yet they're still taking donations from the Idaho potato industry, which has a super high glycemic index, right? So there's a lot of there's a lot of things going against the average American citizen because they don't have the medical knowledge and they think these things are, well, it's FDA approved, it's got to be safe, and all of this. But the fact of the matter is that if you go into the grocery store, they say what an average grocery store has like 500,000 items. You probably eat 100 and that's it. The rest of them are all not so good for you, right? So it goes back again to being able to educate the public. And I'm not saying that they need to regulate and take all of these things off the market. We're a society that's based on freedom, but freedom should be based on education and having the right to know that soda's not good for me, whether it's artificially sweetened or it's got the full cane sugar or whatever. But if you educate them, it's their choice whether to buy it or not. Now in smoking, pretty much everybody understands smoking's probably not the best thing for you, right? And you can see the incidence of smoking has greatly dropped. But what did a lot of the companies do, like Philip Morris, after that happened? In order to create wealth for their shareholders, they then bought food companies. And then they spiked them with all of these things. The food scientists figured out, well, if we put this little thing in, it's going to make it that much more addicting. It's kind of like a Coke dealer in his basement or something, figuring out, man, if I put this little extra molecule here, I'm going to make them use 10 times more than they did before. It's a very questionable industry, but that's a big problem. But you're right. I mean, our country is a very sick country. I was in Europe a few months ago, and I like to do these little what I call my airport epidemiological studies. So I'll be sitting there and bored, waiting for the flight to come in. And I'll say, okay, the next 10 people I'm going to survey, what's their body type? Do they look healthy? Blah, blah, blah. And over there, I was maybe 1 or 2 out of 10 were not ideal BMI and looked somewhat unhealthy. You do that same experiment at the Atlanta airport, it's like 8 or 9 out of 10. We're a very fat, sick society in the United States.
Yeah, very well said.
Yeah.
Okay, Dr. Barrett, it's been an absolute pleasure. I want people to connect with you. What are the best ways to connect with you, your team, the things that you're working on?
Probably the best way to connect with us is just to go to usneuropathycenters.com. I would like to put a plug in for the Association of Extremity Nerve Surgeons. That's AENS.us. It's a group of surgeons that are very like-minded that do this type of work. And so patients throughout the whole United States can go to that and find a provider in their area that can help them.
Amazing. We'll link that below, and I'm sure I'll have you again.
Oh, great. I look for you to come on my show.
Sounds good.
All right. Thanks.
Awesome.